Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, my friends and colleagues. Thank you, Mr. Chairman, for the kind introduction. And thank you for having me and my colleague, Dr. Ruqayya Mir, in this debate that is sponsored by Roche. My talk today will be taking the part of starting early treatment with high efficacy DMT. My name is Mustafa Shakra, and I am neurologist at Sheikh Khalifa Medical City. This is my disclosure, and this is my agenda. Okay, let me start with this classic graph of natural history of multiple sclerosis. As you can know, the pathogenesis of multiple sclerosis is very much complex. It consisting from neuroinflammation in addition to neurodegeneration. The picture of neuroinflammation is very much remarkable at early stages of the disease, where you can find frequent relapses and the frequent GAD-enhancing lesions. While at late stages, in fact, you find accumulation of disability and evidences of brain and cord atrophy. Now, what we are missing, in fact, clinically, at least at early beginning of the disease, there is part of neurodegeneration that is starting even at early stages of the disease. We know this from pathological studies and biochemistry that had shown, even in the early course of the disease, that there are pathological evidences of axonal damages, as it's seen here by green, or accumulation of amyloid precursor protein that are indicating active neurodegeneration process as early as even 1 year after diagnosis. This is another study that shows indirectly that there is a neurodegeneration process underlying even early stages of the disease. This study looked at CIS group of patients, and they found that in up to 57% of them, there is significant cognitive impairment when they were compared to matching competitors of healthy control. So probably the reason that we don't appreciate clinically the early neurodegenerative changes or clinical sign is related to compensations mechanisms or reserve capacities that might include cortical remodeling, remyelination, or even recruitment of other neuronal pathways. Although we know that all these reserve capacities are going to fade over time, and we can, at late stages, appreciate clinically and radiologically evidences of neurodegeneration. My second part of the talk is about starting early treatment, preventing the possible neurodegeneration and delay the occurrence of disabilities. This is one of the landmark studies that had shown clearly that starting early treatment after diagnosis is protecting against neurodegeneration. This included almost 650 patients, and they were followed up to 200 months, and patients were categorized according to starting or initiating disease-modifying therapy, regardless of the type of therapy. And what they found that starting early is protecting against disability, as you can see here. This similar study came from Danish registry, and it shows probably same outcome. They looked at ADSS score of 6, and they categorized patients according to starting early within 2 years after diagnosis, or late after between 2 and 8, and they followed patient up to 20 years. And it was remarkably that starting early treatment protecting against disability. So what about starting early with high efficacy DMTs? Again, we have multiple studies to support starting early, not even early with any type of medication, but with even high efficacy treatment. And this study looked at one group of patients who were started high efficacy DMTs when they were compared with patients who started of medium effect DMTs. Here, as you can see, the high efficacy DMTs that included natalizumab, fingolimod, alemtuzumab, rituximab, and ofatumumab, while the medium effective DMTs that included the platform medications. The primary endpoint for this study was probability of getting first on treatment relapse and the worsening confirmed 6-month confirmed ADS score worsening. And obviously the high effective DMTs were very much superior when they compared with the medium effective treatment. Another evidence came from MS space when they compared even the high efficacy therapy with the platform therapy, considering that the primary endpoint was the secondary progressive multiple sclerosis. And they followed patient up to 9 years. And this shows clearly that patients who started early with high efficacy DMT therapy were less likely to converted to SBMS within 9 years. This is another comparison of starting early, either following the early intensive therapy or DMT treatment or escalation approach. And the primary outcome was sustained accumulation of disability. And what they found, in fact, that after follow-up for 16 years, that median time to sustain accumulated disability was 6 years in early intensive therapy and compared only for 3 years for the platform or with escalation in the other arm of the study. This is from Opera study that included starting early treatment with high efficacy treatment of Ocrevus in comparison with the platform therapy of Rebif, and they followed patient up to 2 years. And you can find here that there is remarkable superiority of Ocrevus over Rebif in protecting against disability. So what guidelines are telling in this regard? Or we know that the McDonald criteria were revised in 2017 in order to speed the diagnostic process and avoid any chance of misdiagnosis and to facilitate the early starting of treatment. Because of this, now we are considering oligoclonal bands as equal for dissemination and time. We consider symptomatic lesions as an evidence for dissemination in time and space and same moment, and we consider like cortical lesions are equivalent to juxtacortical lesions. Even guidelines, European, American, all guidelines are strongly advised and recommend to start early treatment for multiple sclerosis after diagnosis. However, they don't clarify which type of disease-modifying therapy to be started as early as possible. We have also objective barrier to treatment. It's not because lack of recommendations from regulatory authorities. We have objective even barriers to start early treatment. Some of them are related to financial issues or reimbursement. some of them due to lack of diagnostic tools, some like difficulty of identifying symptoms, difficulty in diagnosis MS. Some of them are related to lack of MS specialists, etc. In last part of my presentation, I will give a real-time or real-world experience about Ocrevus as a high-efficacy treatment that was compared to Rebif and starting very early after diagnosis, with long-term results that are available now for up to 6 years. This is the design of study that is known to everybody of us, I believe. So initially the double-blind phase, then subsequently the open-label extension phase. As you know, Ocrevus is anti-CD20 monoclonal antibodies that is prescribed as infusion every 6 months in comparison to Rebif that is subcutaneous interferon that is prescribed 3 times weekly. This is a good example of a platform therapy. This is a good example for a high efficacy treatment. The follow-up was blinded up to 2 years with then extension for open label. Till this point, we have the data available for 6 years. After 2 years, with open label extension, all patients were in fact getting the same treatment of ocrelizumab. The primary endpoint was annual relapse rate. And as you can see, within the first 2 years, there is a remarkable reduction in the annual relapse rate in favor of Ocrevus in comparison to Rebif. The reduction is almost 50%. However, with extension, both arms act in the same way. And we know now by 6 years that the rate of relapse on patients with Ocrevus, regular Ocrevus treatment is almost once every 20 years. When it comes to disability, as I explained before, there was remarkable superiority of Ocrevus over Rebif. However, after all groups of patients were switched to Ocrevus, both arms behave in the same way. However, still the group who started Ocrevus late in the course of the disease, they did not catch up with the patient of multiple sclerosis who started Ocrevus early in the study. Although rebaselining showed that after or during the open label phase, there was no significant change in the deterioration of disability between 2 groups. Same can be said for the improvement in ADS scoring. Again, there was remarkable superiority of the Ocrevus over Rebif. However, after the switching to Ocrevus, both groups act in the same way. Similar can be said when it comes to brain volume loss. So when it comes now to conclusion, I believe starting early with high efficacy DMT therapy is protecting against disability, clinical relapse, radiological changes, and brain volume loss, is keeping patient and maintaining patient in NIDA status for longer time. We have to remember that time is the brain. Again, not only in stroke. So we have to hit hard when the substrate for all this high efficacy DMT therapy are available when inflammation is remarkable. Otherwise, if we are late, we are missing this opportunity for these medications to act effectively. By this, I would like to thank your attention. Thank you very much.